So, Dr. Darryl Leong is an associate professor in the Department of Medicine at McMaster University. He's the director of the McMaster University and Hamilton Health Sciences Cardio-Oncology program. Dr. Leong completed his cardiology training, Doctor of Philosophy, Master of Public Health, and Master of Biostatistics degrees at the University of Adelaide in Australia. He completed a fellowship in cardiovascular imaging at the Leiden University Medical Centre in the Netherlands before relocating to Canada. So, without further ado, I will introduce Dr. Leong.
Thanks so much, Mayor, for the introduction. Okay, terrific. And hopefully that advances to my disclosures.
Yep.
Great, thank you. And I should add as a disclosure that I am a cardiologist. And so this presentation is obviously going to be a little bit slanted in a cardiovascular direction. And so a natural question is, why should a cardiologist be speaking with you about cardiovascular disease when this is the Prostate Cancer Foundation of Canada? This graph here shows the causes of death in almost 750,000 Americans with prostate cancer. The red columns you can see represent the number of deaths due to cardiac disease, and the blue columns the number of deaths due to the prostate cancer. And I think what you can appreciate from this graph is that if you have non-metastatic prostate cancer, you're more likely to die of cardiac disease than of the prostate cancer itself. And that's a statistic that surprises many of my colleagues and many of the patients that I get asked to see who have prostate cancer. In the bottom left, you can see a statistic, and I'm going to present quite a bit of statistics, but we'll try and explain it because I know there's a fairly educated audience. And what that statistic tells us is that even if you have metastatic prostate cancer, the SMR, standardized mortality ratio of 1.48, indicates that you're 48%, so nearly 50% more likely to die of cardiac disease than a man who does not have prostate cancer. And so even with metastatic disease, the risk of cardiovascular death appears to be higher than what we would expect if you have prostate cancer. Now, as a cardiologist, we consider you to be at high risk of having cardiovascular disease or developing cardiovascular disease if your risk works out to be at least 2% per year. Now, some people will interpret it one way and some people will interpret it another. 2% per year might not seem to some people like a very high risk of developing a heart attack or a stroke. But if you consider a lifetime horizon of, say, 10 years and times 2% by 10, a 20% risk of a heart attack or stroke over the next 10 years may be something that is considered unacceptable to many people. And so that's why we use this threshold. I want you to bear that in mind when we look at population data from Sweden, which looks at the incidence or how commonly cardiovascular events occur each year as a percent, both before and after starting various types of hormonal therapy. So you can see that for ischemic heart diseases like heart attacks and other coronary artery diseases, heart failure and strokes, those rates, if you tally them all up on the left-hand side of each column, would clearly exceed 2% per year. And after the various hormonal therapies, be it an anti-androgen like bicalutamide or leuprolide as a GnRH agonist or another GnRH agonist, you can see that the incidence of cardiovascular events increases to exceed 2% per year. So why are folks with prostate cancer appearing to be at high risk of cardiovascular disease? And this was a question that we wondered about and led us to start a study with the help of Movember initially and more recently with the Canadian Cancer Society. At this point, a few years ago, we had recruited almost 2,500 Canadians with prostate cancer, mostly early stage disease. And on the right, we get some insights into cardiovascular risk in this population, because you see that on the vertical axis, almost a quarter of these individuals had some kind of a cardiovascular disease, even when they were diagnosed with prostate cancer. So it's common to have the both coexisting. And on the left-hand side, you'll see that cardiovascular risk factors, so the things that lead to developing heart attacks and strokes, they were also common in patients with prostate cancer, especially having a high cholesterol, where almost 2/3 of individuals had a higher than desirable cholesterol level. Over half of people were either current or former smokers. Well over a third had high blood pressure, and a similar number would be considered obese, while nearly 1 in 5 had diabetes. So cardiovascular risk factors and diseases are common in individuals with prostate cancer. Nowadays we think that we do a pretty good job at treating a lot of these cardiovascular risk factors like blood pressure and cholesterol, etc. Well, is that actually so? Here are data from a friend of mine in the United States, from Pennsylvania, Dr. Key's group, where she looked at how well these cardiovascular risk factors were controlled in 90,000 US veterans from an administrative database there. And you can see that between 1 in 5 and 1 in 3 of these veterans did not have good control of their cardiovascular risk factors. Now, an important point when we look at this data are the sorts of levels or thresholds of these risk factors that they considered to be or represent good control of the risk factor. And as a cardiologist, I can tell you these are pretty liberal. So we've got a couple of remaining questions. One is, are these data also true in Canada? And secondly, if we apply some more stringent targets, which we currently do, how poorly are risk factors controlled, or how often, on the other side of the coin, are people at target when it comes to their blood pressure, their cholesterol levels, etc. So again, using our data, mostly from Canadian patients, but now including folks from some other countries like Brazil and Australia and Israel, we see that actually, when you take a more stringent view of cardiovascular risk factors, they're actually pretty poorly controlled in our population. On the pie chart in the top right of this figure, you can see that about half of patients with prostate cancer have inadequate control of the majority of their cardiovascular risk factors. And on the top left of the figure, you can see the sorts of risk factors we're talking about. So almost everyone had central obesity, which we measure using the waist to hip ratio you might have heard of before. 3/4 of patients did not have blood pressure levels that met the guideline recommended targets, and half of patients did not have cholesterol levels that were at target according to cardiovascular guidelines. 1 in 5, by their own self-report on a questionnaire, would be considered inactive physically, and 1 in 10 were still smoking. We tried to understand why these patients did not have great risk factor control, and we looked at what characteristics were linked with or associated with poor control of these various risk factors. One interesting one that stood out, and a theme we'll come back to, was physical frailty. And we can talk about how we measure that, but it's really a measure of a number of physical characteristics. And we found that if you were frail, you had more than twice the likelihood of being poorly controlled when it comes to risk factors than if you were physically robust. The other sorts of risk factors were not taking a cholesterol lowering pill, having high blood pressure, and getting older, quite simply. And so we're starting to understand here that risk factors are common. They don't seem to be well controlled in this population. A common question that we get asked, though, is does hormonal therapy lead to cardiovascular disease? At least a third and even closer to a half of patients with prostate cancer will be recommended hormonal therapy at some point in their lifetime. So in answer to this question, I put 2 bullet points here, and these are really my takeaway messages. Some types of research called observational studies would suggest that there could be an association or a link between androgen deprivation therapy and cardiovascular disease, and this could potentially be because ADT worsens a number of cardiovascular risk factors, as we'll talk about in the next few slides. Importantly, data from clinical trials of androgen deprivation therapy, where patients either got ADT or no ADT, or ADT or versus delayed initiation of ADT after some lag period, did not show that there was any worsening of the risk of dying of cardiovascular disease with ADT use. So my takeaway from these data are that ADT may have at most a pretty weak relationship with cardiovascular diseases like heart attacks and strokes. But I think that there's room and a need for more research to understand the nature of this relationship a little bit better. You might ask, well, why did these different types of studies lead to these different kinds of conclusions? And I think it's important to point out that there's a lot of technical and methodological differences and limitations in the different types of study designs which is why we need more research and why we're undertaking more research to understand the relationship between androgen deprivation therapy and cardiovascular risk factors and cardiovascular disease. What I think many people will acknowledge and appreciate is that hormonal therapy leads to weight gain. These are some early data from Dr. Matthew Smith, almost getting towards 20 years old now, looking at the change in weight and waist circumference over the first 12 months of starting leuprolide as hormonal therapy in 26 patients. And you can see from the upward trajectory of these graphs that weight and waist circumference increase over 12 months. And that on the vertical axis is about a 3 to perhaps a 4% increase in those measurements over time. So why is obesity and adiposity important from a cardiovascular perspective? Here's some research in the general population where we looked at 1.5 million adults around the world and measured obesity using a commonly measured metric called the body mass index that you might have heard about, which is the weight divided by the height squared, when height is measured in meters. Now, this is not a perfect measure of adiposity because, you know, bodybuilders will have an elevated BMI but not necessarily be obese. But we find at a population level, when we're looking at thousands or hundreds of thousands of individuals, it's a reasonable surrogate or measure of obesity. And what we find is that as your body mass index increases from a mark of 25, which is regarded as healthy, you see a progressive increase in the risk of cardiovascular events, about a 7% increase in the risk of developing a heart attack or cardiovascular disease for every kilogram per meter squared increase every 5 kilograms per meter squared increase in body mass index. So why does obesity predispose to cardiovascular disease like this? Obesity is really closely linked to diabetes. Here are data, again from the United States, looking at administrative data. The red curve shows you how commonly diabetes is developing in patients treated with ADT as compared with the blue patients with prostate cancer who did not receive ADT. And what the statistics there show us, that HR, the hazard ratio of 1.61, is that if you get treated with ADT, you were 61% more likely to develop diabetes during follow-up than patients who did not receive ADT for the management of their prostate cancer. So clearly ADT use is associated with diabetes as it is obesity. Blood pressure is also really closely linked to adiposity and obesity. These are data from Taiwanese patients with prostate cancer, looking at the chances of getting hypertension if you had received ADT in that red dotted line versus prostate cancer patients who never received ADT. And the hazard ratio of 1.78 there in the middle of the screen tells us that you are 78% more likely to develop high blood pressure if you were treated with ADT compared to no ADT. Another cardiovascular risk factor that really gets underappreciated, I think, is muscle strength. This can be pretty simply measured for research purposes and even in the clinic using this device you see here called a hand grip dynamometer, which simply measures how strongly you can grip the device in kilograms or in pounds. And while it measures your grip strength, that pretty crudely correlates with muscle strength in all sorts of areas throughout the body, and we can use it as a global estimate of what muscle strength is for a person. When we looked at the relationship between muscle strength using this device and the risk of developing various cardiovascular events like a heart attack, stroke, or dying of cardiovascular disease, we found that for every 5 kilogram lower hand grip strength, there was a 7 to 9% higher risk of heart attacks and strokes, and there was a 17% higher risk of dying of cardiovascular disease. So I think muscle strength seems to be a marker of risk of adverse cardiovascular events occurring, and we need more research to understand this because it really is underappreciated. Again, anecdotally, many people will acknowledge that hormonal therapy affects muscle strength, and here are some of the early data to support this. If you look at the muscle strength amongst prostate cancer patients who did not get treated with ADT in the dashed line here, you see that it remains overall fairly steady over a 12-month period, but those treated with androgen deprivation therapy in the solid line have a progressive decrease in their muscle strength. So we see some research done in up to about 100 patients, but we wanted to be very confident of how much ADT is affecting these various physical measurements. And so we've done some research now in over 3,500 patients from several countries, looking at the change in various physical measurements over 1 year in patients who are treated with ADT in the red lines here, as compared to patients with prostate cancer who did not receive ADT in the dashed blue lines. So in the top two graphs, you can see that clearly weight and waist circumference increase more rapidly in patients treated with hormonal therapy in the red lines than in patients who did not receive hormonal therapy. In the bottom left, you see that gait speed, which is measured by the time it takes to get up, walk 3 meters from a chair, turn around, walk back, and sit down again. That did not change in patients who did not receive ADT over a period of 12 months, but the time it took did increase significantly in patients receiving hormonal therapy, indicating that their gait speed was slower. And when we looked at a measurement of hand grip strength in the bottom right, we see that interestingly, both patients with and without ADT exhibited a reduction in muscle strength over a 12-month period, but this was more accelerated in patients who were treated with hormonal therapy in the red line. And importantly, these estimates of the effects of androgen deprivation therapy took into account any differences in a number of characteristics you can see on the right-hand side there at baseline. So we can't attribute the differences between these two groups that we're observing to things like differences in alcohol or tobacco use, differences in physical activity levels, etc. So it does leave us to really think that hormonal therapy might be accounting for at least a large proportion of the differences between these two groups that you can see. So having done this kind of research, we wondered, well, what is the relationship then between these physical measurements and the risk of developing some of these cardiovascular events like heart attacks, strokes, and heart failure in the future? To date, we've followed participants in this research for an average of about 3 years. Now, during that time, 5% developed a cardiovascular event like a heart attack, stroke, or dying of cardiovascular disease. What was really interesting is in the top two graphs, we've divided the population here that we're researching into quarters, basically, of weight and of waist circumference. And you can see all those colored lines are really overlapping, indicating that there was no difference in the risk of these cardiovascular events, irrespective of which weight category or which waist circumference category you fell into. But if you look at the bottom two graphs, what was really interesting to us is the dashed black curves at the bottom part of the graph, which tells us that if you have the slowest gait, if you're in the lowest quartile of gait, or you're in the lowest quarter when it comes to hand grip or muscle strength, the chances of developing a cardiovascular event were substantially higher than people whose muscle strength and gait speed were faster than that. So this is a new finding that I don't think has been reported previously, but measures of muscle strength seem to be go hand in hand, if you like, with the risk of future cardiovascular events more strongly, to pardon the pun, than measures of obesity or adiposity. So I think this is something that we're going to be exploring with more interest with our research. Now, today I've talked a lot about ADT as one big whole thing. And of course, you'll all know that most androgen deprivation therapy is delivered by GnRH agonists. There is a small proportion that is provided by GnRH antagonists like Darryl or Lugolix. Very few people nowadays will have surgical castration, but there are, of course, many drugs that act on different parts of the testosterone axis to reduce the effect of androgens on the prostate cancer. Some act on the androgen receptor, others act on the adrenal gland to stop androgens being produced or synthesized via the adrenal gland and then affecting the prostate cancer's growth. So these drugs all have different physiologic effects. They have different effects on the hormonal system. As an example, the GnRH antagonists like Relugolix and Digarelix are the ones available in North America at this time. They lead to a more rapid and complete suppression of testosterone and other hormones you can see here. And so one question that arises is, does this influence the effects of the hormonal treatment on cardiovascular risk? So what I'm showing in this graph is some information from Jonathan Pinthas, who's a colleague of mine, who took mice. So these are not humans, these are mice data. And he administered an orchiectomy, surgical castration, to some of the mice. He administered leuprolide to other mice and Digarelix, which is the GnRH antagonist, to another group of mice, and compared them to a control group. So 4 groups of mice. He then measured over some time, and after feeding them, how much plaque they had in their aortas, the big blood vessels in their body, as a measure of cardiovascular effects of these different hormonal strategies. What you can see in the middle 2 columns is that the amount of plaque in the mice who either had surgical castration or leuprolide was higher than mice that did not receive any treatment, and was higher also than mice who were treated with the GnRH antagonist Digarelix. And so this was some of the early research to suggest that maybe the antagonists were different to the agonists when it comes to cardiovascular side effects. A couple of years ago now, we published this, what we call meta-analysis. And this is a way of summarizing clinical trials data. We looked at all of the trials that compared a GnRH antagonist with a GnRH agonist in a randomized trial design. And what we found was that the GnRH antagonists, mostly Digarelix in this study, although there were some early data from Relugolix, led to, or was associated with, about a 50% reduction, so about half the rate of cardiovascular disease and cardiovascular deaths compared with the GnRH agonists like leuprolide. And so this would seem on the surface of things to be a really big finding. If you've got a prostate cancer drug that reduces the risk of cardiovascular death by half, surely it's a really good thing. Why isn't this being recommended for everybody who needs hormonal therapy? Well, an important part of our research, and I think probably reflected in the current prescription guidelines and by regulatory agencies internationally, is this kind of table here. This table tells us about the quality of the data in the various trials that we researched and we included in our study. And you can see that the plus signs indicate that the study was of good quality when it comes to things like randomization and certain biases. But these studies were pretty uniformly of what I would consider low quality or high risk of bias for other characteristics, like blinding of participants and study personnel and blinding of outcome ascertainment. Now, these are all technical things, but what they mean is that we cannot be certain that the results and the findings reported in these trials were not influenced by either patients or research staff knowing whether they got the GnRH antagonist or the agonist. And so our confidence in these data is certainly not 100% and not enough to recommend these drugs for everybody. And perhaps, later on, we can talk, I guess, at a more informal level about, the potential role of GnRH antagonist versus agonist and what the future might hold for this kind of research and these kind of concepts. One trial that was supposed to address this uncertainty was a trial that you might have heard of called the PRONOUNCE trial. So this trial was really unique in a number of respects because while it did compare the GnRH antagonist Digarelix with the GnRH agonist leuprolide, it was specifically designed to see whether Digarelix could lead to lower risk of cardiovascular events than the GnRH agonist. And it was the first trial that did this in what we call a pre-specified or prospective manner, meaning that this was the main research question. This wasn't some post hoc or after the fact look at the data trying to see what it shows. So the trial was all designed to look at improvements in cardiovascular risk in the GnRH antagonist group compared with the agonist group. Patients could get into this trial if they plan to use ADT for at least 12 months, had not had ADT recently or at all in the past, and already had cardiovascular disease, be it in their coronary arteries, in their heart, cerebrovascular diseases like a previous stroke or diseases of the brain, or peripheral arterial diseases in the legs and other organs there. So this was, was thought to be a group at high risk of having future cardiovascular events. In this trial, all of the patients involved saw a cardiovascular physician and had their cardiac treatments optimized. They were randomly allocated to either get Darryl or leuprolide and were followed up for 12 months. And the main outcome of interest in this study was death, heart attack, or stroke. So what happened in PRONOUNCE? Well, for a number of reasons, they found it very difficult to recruit participants into this study. They also found that the occurrence of heart attacks and strokes and death were lower than what they had anticipated. And unfortunately, the sponsor of the trial, Ferring Pharmaceuticals, decided to close the study early when only 545 out of 900 planned participants had been enrolled. By that time, the outcome of death, heart attack, or stroke had only occurred in 26 patients. And that's really too small a number for us to be able to draw any strong conclusion. So unfortunately, because this study, for a number of reasons, did not go through to completion as planned and had a number of methodological issues about it, we still cannot conclude whether Darryl has any effect on cardiovascular risk compared to leuprolide. And in fact, a more recent meta-analysis, a more recent version of the paper I showed you a couple of slides ago, confirms that we still have a lot of uncertainty in this space. And as I said, as we move forward with this presentation or afterwards, we can certainly discuss this further. Increasingly, though, the newer androgen receptor signaling drugs like abiraterone, enzalutamide are coming into play for patients with prostate cancer and at earlier stages of the disease as well. One question which we often get asked is, what are the effects of these drugs on cardiovascular disease and cardiovascular risk factors? Remember, of course, that patients getting prescribed these kinds of drugs are almost always on some form of baseline hormonal therapy like leuprolide or goserelin anyway, to start with. What we can see here in randomized controlled clinical trials is that both abiraterone and enzalutamide are associated with a higher risk of developing hypertension than not taking those drugs. And this appeared to be particularly strong an effect with enzalutamide. We also see that abiraterone and enzalutamide lead to an increase in fluid retention, or the medical term for that is edema. And edema in places like the lungs causes something that we call heart failure, which can make people feel short of breath. So I think there's some, again, evidence that these drugs are likely to have some sort of a cardiovascular effect. This is supported by data from the Swedish population, again, looking at the risk of developing cardiovascular diseases like heart attacks and strokes and heart failure in patients getting treated with abiraterone or enzalutamide in the blue curves, compared with patients with prostate cancer who did not receive those drugs. What the statistics at the bottom of the screen tell us is that abiraterone users were 19% more likely to develop cardiovascular disease than patients not treated with these androgen receptor signaling inhibitors. And the increase in risk for enzalutamide patients was 10%. So certainly some population data there to suggest that over and above any increased risk that's conferred by your standard androgen deprivation therapy with a GnRH agonist in most cases, abiraterone and enzalutamide at least do seem to be associated with an add-on and higher risk of developing cardiovascular events. So if we kind of accept the data that I've shown you so far, that patients with prostate cancer are at seemingly high cardiovascular risk, androgen deprivation therapy certainly increases cardiovascular risk factors and may increase the risk of cardiovascular events like heart attacks and strokes. and the newer androgen receptor signaling inhibitors may increase the risk even further again, what can we do about it? If any of you have tried to get a referral to a cardiologist, you'll appreciate that it is very difficult to see physicians with a dedicated cardiovascular interest. There are simply not enough of us to be able to see everybody, I would say, who may benefit from seeing a specialist physician. One initiative that we're working on to try and address this is to empower patients and their caregivers and various important people in their life to take matters into their own hands. We've developed an application which is accessible on a smartphone, on a tablet, or on a computer, but it's a web-based application that is currently being piloted with our colleagues at the University of Pennsylvania. What happens is when patients register to use this application, they get a page like this, and they put in some pretty simple detail. And these details will include things like their cardiovascular risk factors. And you might say that, well, haven't had my cholesterol checked, I'm not going to know what these are. But you'll find that this risk calculator works almost irrespective of how much or how little data is available to put into it. It will provide an estimate based on published risk scores. And the estimate will be shown something like this, where we're able to tell patients and their families how high the risk is of developing a heart attack or a stroke over the next 10 years. It's important to note that these risk calculators are based on information from the general population. They're not based on patients specifically with prostate cancer. So there is a caveat. They may not be as accurate as we would like. We're working, doing more research, including using these kind of data to help refine the risk calculator. So we give back to patients more accurate prediction and more accurate information. But this is the best we have to go on right now. At the bottom of the screen, you can see some recommendations, and those will be tailored to each individual and the data that they put into the application. So for instance, it would be stupid to say to somebody who's never smoked in their life and never intends to quit smoking. So the recommendations that we're making are really tailored for the information you provide us about cardiovascular risk. So like I said, at the moment, this application is undergoing some pilot testing in the United States. And if we find that the information that patients or their caregivers are entering into it are accurate and therefore give us an idea about their risk factor profile, then our next step is to see what we can do to try and address that risk in a much larger way than can be addressed by one-on-one physician consultations. So this is where I think the field is at in terms of cardiovascular disease in patients with prostate cancer. Now, I did say in my very first slide that survivorship is it's not just cardiovascular disease. There are lots of other issues. I'm not going to pretend to be an expert at these because I'm not. But what I can tell you is that we're leveraging the research that we've done so far to try and understand a little bit more about some of these other issues in survivorship. As an example, we administered to participants in our research the PHQ-9 questionnaire, which is a pretty good measure of whether or not somebody is depressed or feeling depressed. And what you can see here is the risk of death in patients who were depressed in the red graph versus those who were not depressed according to this questionnaire in the dashed blue line. And what's very clear is that the risk of dying over 40 months in patients who are not depressed was about 10%. But in people who were depressed, that risk of dying over that 40-month period was 15%. In other words, 50% higher risk of dying if you were depressed compared to if you weren't depressed. So set aside the fact that depression is a nasty thing and is important for people just because of how it makes them feel. The fact that depression is associated with a higher risk of dying is arguably also extremely important. And we need to do more research like this to understand what it is about depression, whether it's the depression itself, whether it's choices that are being made. We need to understand more about depression in patients with prostate cancer. And so a lot of research is now going to happen in this space. In our case, we have to be grateful to the US Department of Defense, who have asked us to look further into this question over the next several years. And this is just, again, the kind of the tip of the iceberg, because As you will know better than me, there are many issues to do with survivorship in patients with prostate cancer that need more light shone on them. Hopefully, the research and the work that we're doing and others are doing can help contribute to that. So with that last slide, I'd like to thank the various organizations and pharmaceutical partners that are supporting our work, and hopefully it'll be valuable in the future to inform how patients with prostate cancer, their caregivers, and their physicians help to address these various survivorship issues. Thank you very much for your attention.
Thank you so much, Dr. Leong. That was a great presentation.